Hello, and welcome again to the Surgical Clinics podcast. Surgical Clinics is a bi-monthly publication consisting of review articles devoted to a central topic important to general surgeons. Surgical Clinics is published for over 100 years, and the series and the podcast can be found at www.surgical.theclinics.com. I'm John Vassallo, the managing editor of the series here at Elsevier, and for our 13th podcast, we'll focus on the June 2024 issue on colorectal surgery. Colorectal disease is incredibly common and significantly impactful to patients. Unfortunately, the surgical management of these processes is not always straightforward, and commonly encountered issues are hotly debated. Here to discuss these issues with 4 articles from the volume will be our consulting editor of Surgical Clinics, Dr. Ron Martin, senior surgeon from the Department of General Surgery at Pullman Regional Hospital and Clinic Network in Pullman, Washington. Joining him will be the guest editor of the colorectal surgery issue, Dr. Quentin Hatch, Program Director and Chief of Colorectal Surgery in the Department of Surgery at Madigan Army Medical Center in Tacoma, Washington. Welcome to both of you, and over to you, Dr. Martin.
So, Dr. Hatch, Quentin, it's a pleasure to see you. I miss working with you down the hall a lot. I miss having you around to keep me straight on these things, and just wanted to thank you and all your colleagues for putting together this issue on colorectal surgery. As we talked about before, we could spend an entire podcast on even a part of any one of these articles and make great use of our time. But I was thinking we were going to start out today with a chapter actually from you and one of your colleagues, so Dr. Van Eaton and yourself, on surgical emergencies and inflammatory bowel disease. And I think this is something that every general surgeon who hasn't had additional training in colorectal surgery needs to keep up with and needs to pay attention to, because there's a lot to know, and the initial maneuvers, in my opinion, really set the stage for what kind of success you're going to have down the road. So, let's just start out with what might seem like a basically simple question, but I don't think it is. But give us your thought in terms of emergencies, how UC and Crohn's fundamentally differ and how they're alike. Because we're basically looking at hemorrhage, obstruction, perforation, some sort of intractability, sepsis, toxic megacolon. So give us, when you look at that and you're looking at somebody and you don't know what's going on, how do you approach it to try to decide if you're dealing with UC or Crohn's or something different?
That's a great question. And fortunately, a lot of these patients are not presenting for the first time with IBD. Most of the time, in my experience, it's already a known diagnosis, but not always. And I think if we just look at purely the numbers, the majority of Crohn's patients are going to be small bowel or small bowel and colon. And they typically present less frequently with bleeding and more frequently with obstructive type symptoms from stenoses. So usually they present a little bit different clinically in terms of just, as we all know, Crohn's disease is going to affect different portions of the bowel. So that can kind of clue you in. But the reality is, I don't really look at IBD and try to differentiate necessarily Crohn's versus UC, particularly in the urgent setting. We may have, if it hasn't already been diagnosed, we certainly have to have inflammatory bowel disease in our differential diagnosis, but the treatments medically are largely the same, and surgically it's just get them out of trouble. There are some reconstructive options that are going to be a little bit different down the road for those two, depending on what surgeries we have to do to get them out of trouble. But honestly, when I first look, my first thought is not, let's figure out if this is UC versus Crohn's disease. Figure out how we get them out of trouble, and then we figure out what they've got and what to do about it later on.
Yeah, I mean, when I look at these in my approach, the very first thing I want to try to figure out is, do these people clearly have peritonitis or don't they? And that's, do they have one of the indications that you need to be into the OR fairly soon, if not immediately, versus do you have some room to maneuver with medical management prior to that? So what are the triggers for you that make you decide when to sit tight on somebody who comes in sick but maybe doesn't have clearly a proper peritonitis, rigid abdomen, etc.?
Yeah, that is a great question. And I think that's where things have probably changed quite a bit over the years with the introduction of more and more medications, specifically the biologics that can kind of keep maybe the peritonitis at bay, but they're living in kind of a constant state of sickness if they're not in complete remission. I do think that we're probably seeing that more and more. I don't necessarily have numbers to back that up. But it's interesting you bring this up because I literally just gave a talk yesterday about kind of the decision making to do surgery. And the way I explain it to all the patients, regardless of acuity, is it's a spectrum. Certainly, there's the whatever percent at the very upper end of the spectrum where we have to go to the operating room right now to save your life. And as you noted, that's the peritonitis, the free air, the free perforation, massive GI hemorrhage that you can't do anything else about. Those are certainly at the top end of the spectrum. And then you've got the other end where maybe they don't even need medications. They're managing something with dietary modifications and they haven't had symptoms in years and they should never go to the operating room. And then there's the 90% in the middle where it's important to build rapport with patients and make sure that you're seeing the kind of the long-term game plan. I do equate in a way these IBD surgeries with some of the stuff that we do in vascular surgery, where you're always planning 2 or 3 operations down the road to make sure that you're not burning any bridges. But in more specific regard to your question about what to do when there's wiggle room or how do you identify if there's wiggle room. And I think you kind of hit it on the head. And what I was saying earlier about those truly urgent indications, the free air, free perforation, free and the massive GI hemorrhage, if it's outside of those, there's always room for discussion. And so the problem that we run into is probably both surgeons and on the medical side is there's always a new medication coming out. Even since I've been in practice, we've got 3 or 4 new biologics that have come out just in the last 6 or so years. And so it makes it hard for both the clinicians and the patients to decide what to do, particularly in UC where it can be curative. Sometimes it's a blessing in disguise if somebody who's on their 3rd biologic and now comes in, with toxic megacolon from UC, we can say, all right, finally it's declared itself. We're going to get you on your way to not just getting you out of this problem, but toward a surgical cure, which it's not perfect. Nobody wants to have an ostomy, even if it's temporary. But certainly if they've been living with fulminant UC for a long time, it's actually one of the more satisfying operations that we do, whether it's acute or more planned, because they start feeling well.
It is difficult for many people to be able to see down the road, especially when they're sick, to think that I don't want what I think is going to be this outcome and then realize how much better their life would be. Because it's imagining the unimaginable by definition, I guess, is difficult. One of the things in your article that struck me that I should have thought more about this before and probably haven't, and I don't know why, but I'm going to have you educate me some more. It's where in these people who come in urgently, semi-urgently, what's the real role for stool test for various things, and especially infectious issues. And my concern is some of these things you get back more rapidly now than we used to, and some you don't. Like whether it's biofire assays or PCR, I mean, certainly our turnaround's better, but how do you factor in the stool test for either infectious disease or other biomarkers, if at all, in your decision making, or you just have to kind of run the clinical guideline scheme independent of this?
Well, that's a great point. And it kind of depends, just like what we would talk about, on how the patient presents. So whether it's toxic megacolon from C. diff, from UC, from Crohn's, from cytomegalovirus, the urgent surgery for any of those is going to be a colectomy. And so if they really are unstable and unresponsive to fluid resuscitation and everything else, then you kind of are left with no choice. But if it's in that other category that you were referring to earlier, where there is a little bit of wiggle room, I think it's actually pretty critical, particularly the C. diff, because a lot of the patients who have been previously diagnosed and have been on immune suppressing medications the risk for getting fulminant C. diff colitis goes up. And what we've seen is that independent of the immune suppression, B. diff tends to manifest more frequently in these patients. We don't exactly know why. I don't know if it's more frequent hospitalizations or the immune suppression, but you're more likely to see those infectious processes in these patients than you are in the general population. And so, obviously, if you're talking about do we pulse an IBD patient with steroids and further immune suppress them because you think this is autoimmune inflammation that's driving it, or is it an infectious process and you're going to get further immune suppress them and then make them worse off? And so it's really important to try to the best of your ability to delineate that. And if you're in a pinch, you can do both simultaneously. There's not great data to support simultaneously putting somebody on steroids and systemic antibiotics. But these are all those kinds of things you're going to see out there as we struggle with some of these issues.
Well, that dovetails right into my next question. Because as you say, we're either trying to help the inflammatory response work better, i.e. support it with antibiotics, or we're trying to suppress the inflammatory response because somebody stuck the thermostat on high and it won't go down by itself. But the biologics are not always necessarily awesome for wound healing. So what are your thoughts about, do you have any hesitations with using any of the biologics if you think you're going to wind up in the OR in the next 24 or 48 hours, or is it just give them, see what happens, and play the cards as they fall?
Well, the data is a bit mixed with the biologics in particular. There's a couple of, I guess, newer ones on the market, but classically we think of the first ones that came out as our anti-TNF biologics, and we've largely found that infectious complications don't really go up with them. So the risk, anastomotic risks in wound infections and all those sorts of things, we have not reliably seen an increase in those complications when operating on folks who are on a biologic. Steroids, which is kind of our big gun for inducing remission, that is obviously a bigger issue with regard to wound infections and deciding whether or not to do an anastomosis. So if it's one of those patients who were not being forced to the operating room, particularly if they are naive to some of these biologics already, yeah, I think most people are not going to hesitate to start them on biologics. Sometimes you get into a situation, particularly if it's Crohn's disease, where now they've got an abscess and previously undiagnosed, and you'll hear different things in a drained abscess. Do we want to start them? Do we not want to start them? And so there's a little bit more room for discussion there. But for somebody who has not perforated, does not have an infectious complication already from the process itself, most people are going to say, yeah, that's fine to go ahead and start on medication.
Yeah, and that sounds great. And that kind of fits with my thinking. And the broader corticosteroids always give me pause, and if nothing else, make me want to protect whatever I put back together and leave inside folk. But speaking of management, operative stuff, there's a great section that you and Dr. Van Eaton described in your chapter on stump management. And I have never done your buried mucus fistula trick, and I wish I'd seen you do it when we were working together. I've tried, I think, all the other things, but so describe a little bit for us, like say you're going in and you believe you're dealing with UC, you got toxic megacolon, it's not responding, or there's been some other catastrophe. So go through your decision making is, how do you decide? I mean, I think we mostly agree that if you've got to go in a situation like that, that a subtotal or a total abdominal colectomy is part of the deal no matter what, but you correct me if I'm overstating that, at least for UC. And then the rectal stump and what you do with that, go through your thinking on that.
Well, first of all, to the point you made there, the back half of that question, I frequently tell my residents, you never do an emergent proctectomy. I've seen it, only a couple of times for massive rectal bleeding, but that is a very rare one-off. So, but what you have to account for are some of those other things that we've already discussed. So, folks who have fulminant UC, whatever type of fulminant colitis that they have that is forcing them to the operating room. I agree. You're doing a total abdominal colectomy in those cases. But what you're leaving behind is, of course, an inflamed rectal stump, usually in somebody who's been on high dose steroids and biologics, who probably hasn't eaten well for some time, so frequently malnourished. So malnourished, steroids, inflamed tissue, not going to heal well. And I think for all those reasons, we tend to see about a 10% risk of a leak from the rectal stump if you just leave it in there. We're talking all comers here. Mm-hmm. So not insignificant, and with a significant physiologic insult to the patient if it does happen, because they still are immune suppressed and everything else. And so there have been a number of different strategies discussed. Certainly there are people who will just leave it and pray, and there's other folks who will try just leaving a drain there in case it blows out, and other folks will leave a rectal tube, which no patients like that, having something stitched to their anus. That's not fun. And so the way I was trained and what a lot of people do is this thing called a buried mucus fistula. So all it is essentially you bring a stapled rectal stump, you leave enough of it in place to be able to get it suprafascial. So you bring it up right there. It depends on what incision you have, but at the lower end of your midline incision, or for me, a lot of times I'm doing this through a fan and steel. So I just bring it right underneath the fan and steel. I just take neuromuscular bite of the stump and secure that to the fascia, and then I just close skin right over the top of it. And so all that's going to do is, if it does blow out, it just becomes its own mucus fistula once you open the wound and allow it to drain.
How, just out of curiosity, what percentage of those that you bring up do you think that you have to go back and open the wound and open the stump and decompress it?
I would say it's roughly around 10%.
Okay, so that's
I haven't gone back and looked at it, but that just.
I mean, I think the idea is genius. I mean, if you're going to have something leak, you'd much rather have it leak above the fascia than below. I mean,
right.
I think we live with that.
It does present some issues when that happens, because now you've got a draining kind of midline wound down there, and it may continue to drain until you do a completion proctectomy if the inflammation never subsides. So it's problematic from that standpoint, but I would still take that over a free intra-abdominal perforation.
Yeah. Living to fight another day is still living another day.
Yeah.
So I think there's a lot of truth to that. I mean, with Crohn's, as your article points out, factoring in the abscess and stricture is probably a little more prominent than you'd expect with UC. How do you feel about Crohn's and percutaneous drainage? And do you have times when you're okay with? Certainly, if somebody had a limited ileocecal process and everything contained, and you thought you could go in one-stop shopping and take care of business, I might be more game to operate on those people rather than stage it. But for a lot of other people with a contained abscess, drainage and antibiotics and coming back under more controlled circumstances sounds appealing. What are your thoughts?
Yes, if they present with an abscess, I almost always, as long as it's amenable to percutaneous drainage, recommend doing that. The problem is there's always the discussion about, well, now you've got an abscess that is likely going to turn into a fistula if it's secondary to that autoimmune inflammatory process. And so are you going to start them on induction therapy with high-dose steroids while you've got that process going on? But so that can be problematic. My experience is that most patients who present with an abscess will ultimately go on to surgery, but anytime you can do surgery with less inflammation around, the better. Particularly in Crohn's disease, where bowel conservation is critically important. And so if they come in with an acute process, there's frequently secondary inflammation, and you don't know quite what is inflamed from Crohn's versus this abscess versus the perforation. And so if you can get that all settled down to where you get your margins based off the active Crohn's inflammation rather than the infectious process, I think that's helpful.
So, in speaking of that with Crohn's, and I mean, as I was growing up in the game and being taught, the idea with Crohn's was take out the least amount of bowel you can take out no matter what. Preserve as much length of everything as you can, up to and including strictureplasties, etc. But if you're dealing with focal Crohn's obstruction in colonic stuff, what are your feelings about hooking people back up? And if you do you always bring up a protective proximal diverting stoma or not?
That's a great question. So if this is a chronic, stricture, for example, of the colon, I'm not going to obligate them to a total abdominal colectomy. So I will do a segmental resection with a primary anastomosis, and then the diversion. And I think we talk about this in the article as well, or one of them at least. I base that. That's kind of almost an independent decision. So it's not based on whether or not they have Crohn's disease. It's based off their nutritional status and their degree of immune suppression. So if they're taking less than 20 of steroid, just less than 20 of prednisone equivalent, I'm a lot more likely to leave them protected, because really what we don't think about a lot of times is if you're bringing up a loop ileostomy for Crohn's disease, especially if it's temporary, well, you just left them with another anastomosis down the road, and that's where Crohn's comes back. So,
Yeah.
It's kind of, you have to weigh that.
No, that's good stuff. I want to transition a little bit to a topic, one of the other chapters that's similar, but it's colorectal oncologic emergencies, because I think this is going to dovetail into that last answer you gave us neatly. But by Doctors Sullivan, Donahue, and Brown, our Irish contingent apparently, which always proud to see our Irish boys in there. But I think so. To me, when we're dealing with, the colorectal, same thing, hemorrhage, obstruction, perforation. I mean, hemorrhage, in my experience, for most cancers has rarely been something you got to go operate right out of the gates. You can usually do some things in the meanwhile to buy yourself some time. But obstruction and perforation, this is, I think, where the rubber meets the road. And in particular, I want to get your thoughts on colonic obstruction, either mid or distal, with a competent ileocecal valve, because I think a lot of people who are training aren't familiar with what happens when you basically create a closed loop obstruction of the colon. So run us through your thinking on those kind of troubles.
First of all, these patients often present for the first time with this closed loop obstruction, as you know. And so that is it's frequently from malignancy. It's most commonly going to be from malignancy. You can have benign strictures from chronic diverticulitis, or from, UC or Crohn's disease, but most commonly it's going to be an undiagnosed malignancy. And so if anybody comes in with a large bowel obstruction, even if it's perforated, and they generally perforate proximally at the cecum, although the tumor can perforate itself. But I always just encourage everybody to inspect the rest of the colon, and that includes a digital rectal exam, maybe even proctoscopy if you don't feel anything. But you want to try to feel if there's another lesion there. Regardless, you're going to treat them as though they have another lesion there, because nobody just spontaneously perforates unless it's Ogilvy's, and even then, if they haven't had a screening colonoscopy, we can't rule it out. So, my thought process with that is that if they're coming in perforated, you obviously have to address the acute perforation by resecting it.
Mm-hmm.
The tendency, especially if there's in septic shock, is to not do a primary anastomosis, and that's probably good thinking there if they're on pressors and everything else. And so certainly if you're taking out, say, a right colon perforation, you're going to do a right colectomy and an ileostomy. But the danger inherent to that is if you just leave a stapled off end of the distal colon with an obstructing lesion downstream, then you've just left them with another closed loop obstruction, and that will blow out. Or if you do a primary anastomosis, your anastomosis is going to leak because it can't decompress. And so that is when this mucus fistula kind of concept comes in. So you've got to be able to allow that closed loop to drain, and so you may do a proximal ileostomy, and then you bring up that end of the transverse colon or whatever you have left up to the abdominal wall also. So you essentially give them two ostomies, one of which is the mucus fistula, and one of which is draining, of course, the enteric contents. So that's important, and then you can go on to further work up whatever that lesion is.
I think the ones where at least people that are younger than I am, which is almost everybody in the business now, have had trouble is the person who comes in with a distal obstruction that's out of reach. You can't feel it and you can't see it on proctoscopy. But they've got a competent ileocecal valve in their colon's out, and they're sicker than snot. And, in the olden days, in the Turnbull days, there are some side decompressive colonic procedures you can do basically under a little more than local. And with modern anesthesia, you can actually give people propofol and get away with it. But when they're really toxic and circling the drain, that you've got to get that colon decompressed by some means. And I found a number of younger people who basically think you can decompress it with a loop ileostomy, which you can't. And that's the lesson I try to tell them is like, you can't just reach in there and pull up a loop of ileum. You're going to be right where you started off with. And I mean, it's not a great stoma. It's designed for short-term use. But I think your concept of if you don't know that things are open downstream, you have to assume that they're not. And you've got to find a way for retrograde decompression by whatever means. I've not had good luck, although I haven't tried it for probably a couple of decades, trying to do tube decompressions of the distal stump. I don't know, maybe I'd never learned how to do it right or something, but the idea of closing these things over a tube hasn't been great. Had a little bit better luck with things where they're distal, bringing up a loop sigmoid stoma and buying some time, but I'd say probably in the Turnbulls that I've done in my life, which is maybe 6 or 7, the most recent one being about a year and a half ago, at least half of them, if not more, had a synchronous cancer lesion on further evaluation. And I don't know if there's any data to suggest that should be more likely than the general population, but we found something that we wouldn't have found had we not gone and looked.
Those are great points. One of the things I always tell our residents is, especially if they don't present perforated and they've got a large bowel obstruction, you will either decompress it or it will decompress itself. And ideally, we get to it first. And so, like you mentioned, it's usually going to be either transverse or sigmoid colostomy if it's a distal lesion. And sometimes, I'll be honest, so if the lesion itself is sigmoid colon, you're probably going to have to go back to the transverse colon and decompress it. Right. Like just because you're not going to be able to bring up the tumor, you're not going to be able to bring up the descending colon with ease, especially when it's acutely obstructed and hugely dilated. That's what a lot of people don't appreciate is they say, oh, I'll just go do a laparoscopic loop sigmoid colostomy, and the colon is 6 centimeters across and full of fluid. And that's not going to work very well. It's just kind of, sometimes you got to make a decision.
No, it's true. And that is, that's becoming a real thing because people get less and less training with the open stuff in the fallback positions. And as we sort of alluded to in the earlier discussion, and we'll continue it through this stuff is a game of chess, not a game of marbles. You got to be, where does this end up if everything goes well? And, where does it end up, I guess, if it doesn't go well? But you got to be thinking about all your moves and your ability to take a step back and figure out the next problem and how you're going to address it, and not burn your bridges, because there's a lot of bridges to burn in this. This is a bridge-dense environment. But one tool that's come along, though, that certainly didn't exist at the beginning of my training, and it's been around for a long time, though, is our ability to put in self-expanding metal stents. So talk to me about how you approach that. I mean, certainly I feel that's a team approach, no matter what. I don't think it's a one riot, one ranger type situation, but maybe you do your own self-expanding metal stents. But give me your thoughts on percutaneous or transnatural orifice decompression.
So I definitely think there is a role for it, but it also depends on your center. As you mentioned, it is a team effort. And so I have, unfortunately, in my experience, seen more of these go wrong than I have seen used for their intended purpose, i.e. somebody with metastatic cancer that they're just trying to get onto chemotherapy, and so they put in a stent, and then they come in perforated from the stent, and they have to stop their chemotherapy and everything else. So the stakes are high. Yeah. When it is used as a bridge to surgery in the very acute setting. So, the data probably support 7 to 10 days-ish from the time of the stent to surgery. It will allow for bowel prepping and everything else, potentially a colonoscopy to clear the rest of the colon, the size mismatch between the previously obstructed and distal segments tends to get worked out if you operate in that time frame. And I think there is utility in that. Now, it doesn't work as well for rectal cancers because you more frequently have stent migration that's sitting on the sphincter and it causes pain and it's not doing its job in the first place. Right colon stents, while some people do them, it requires some pretty skillful endoscopists, and I don't know that you're going to get that much out of it, as right colectomies and doing ileocolic anastomosis is usually fairly straightforward, particularly since the distal segment is not going to be dilated.
Yeah.
Right. Like you mentioned, it's a competent ileocecal valve, so the ileum's same size, and the right side doesn't really matter. So in this small segment of folks who have a sigmoid or descending colon obstructing lesion with significant size mismatch, I think there is a role for that because you can make it less likely that they'll, or you can potentially improve some of the short-term outcomes.
I think your point that it's got to be a bridge to someplace. Mm-hmm. I mean, I forget that political thing where they were trying to pass a law about building a bridge to nowhere. It was a big joke for a while, but it's got to be a bridge to something. It's not the be all and end all. And I think this is where, at least in the acute care surgery world, I believe in acute care surgeons and I believe in general surgeons being able to do a lot of different things. But I'm also a big believer, as you know, in subspecialty expertise, whether it's my old line of work, pancreaticobiliary stuff, and certainly tremendous respect for your ability as a colorectal surgeon, and I've seen it and benefited from it firsthand. But there are some people that are working in an episodic framework where they don't own the problem long term. And I don't think that they're bad people or anything. I think they don't necessarily see how a decision they make today winds up in somebody else's clinic down the road with options taken away. So I would be reluctant for somebody to put in self-expanding metal stents for an obstructing colon tumor or a rectal tumor, but if they hadn't had a thorough conversation with somebody like you, with a colorectal surgeon saying, yeah, we believe this is a step towards a larger management process that makes sense. And telephones work. People always have somebody they can call. You don't have to do this like you're on Mars and your commo's wiped out. You can actually get some help. But I think the esophageal world kind of got a lot of people excited about stents for a lot of things because it's a different organ system to mess with. But you can't translate everything one for one to different parts of the GI tract. A lot of rules change as you get to the very end, and a lot of rules change as you get to the very beginning. And in the middle, it's kind of a mixture of fuzziness. But speaking of the end, we've got another chapter to cover. I mean, honestly, I could go back and do the first two, just keep going. But the management of the difficult stoma. So now we're talking real chess, maybe 3-level chess. Doctors Merritt and Maldonado, fantastic chapter. And I guess my first thoughts are, if one is considering a stoma of any kind for any reason, the first thing you got to ask yourself, is this the end game or is this a move and part of the game? And go through your thinking on that, because not everybody necessarily winds up in an end game stoma for the same reason.
Right. And so just in terms of decision making about in-game stoma versus temporary stoma, I think we're probably seeing this. This is becoming more of an active part of the discussion as we move toward doing primary anastomosis for bad diverticulitis. So that's been one of the more recent things, but we still don't know who gets a loop ileostomy versus just their primary anastomosis and leaving it, and that's going to be surgeon dependent. I will say that if you're going to do an anastomosis, it's not necessarily easier later. You've got everything right in front of you that first time. So if physiologically the patient is going to tolerate it, meaning, and I'll back up a little bit, if somebody's on pressors and sick and malnourished and immune suppressed and all that, that's not going to be an anastomosis that heals well no matter what, right? Best case scenario, maybe it's stenosis. So that's just not an ideal position to put stoma in. Now, if it's one of these ones where they just got a little bit of pus in their belly and they got a little fluid resuscitation, they're no longer on pressors, you got the infectious nidus out, in my hands anyway, there's really no reason to not do a primary anastomosis in that. you're uncomfortable because of the degree of infection or whatever that you think it's going to increase the rate of leak, you can do a loop ileostomy. But I'm a big fan of doing a primary anastomosis up front if you think the patient will tolerate it. But when it comes to doing, the reason we chose this article is really just twofold. One is, how do you prevent, or how do you make a good ostomy, particularly in a population where it's presenting acutely that may or may not have good ostomy kind of options? And B, if it ends up being a bad ostomy, quote unquote, kind of bad ostomy, how do you manage that after surgery? Because those things come up all the time. I still get questions from the operating room. Hey, this guy's, got a really thick abdominal wall with, thick mesentery and all these, giant upwelling appendages. We can't get it through. We can't get it up to the skin level. So how do we deal with that? And that's, of course, independent of, but I think that does factor into your decision whether or not to make an anastomosis. If you think you're going to have a terrible ostomy, maybe you just put them back together in the first place and bite off on a little extra risk of an anastomotic complication. Obviously, that's a little nuanced. But that's something to keep in mind.
Yeah, I mean, a long time ago, I was put in charge of fixing some systems issues. And one of the things I was trying to get people to buy into, and time will tell if it was ever successful, was that post-operative care is something you think about prior to admission. And post-discharge care is something you think about prior to admission. You don't wait until you're in the operating room or the patient's in the hospital. I mean, emergencies are emergencies. We kind of started out there. Those are the cards that you get called, it's here, what are you going to do about it? But the same thing with stomas, I think. If you have the luxury of time, and probably more often than not one does, first of all, having a good stoma therapist is worth its weight in gold. I mean, that can't be overstated, as your authors concluded. But preoperative marking and knowing where you're going to put things and knowing what your options are depending on what you're going to use. Of course, the more information you give the stoma therapy people, the more likely they are to give you better marking too. So it's a two-way street. But, a long, long time ago, when I was a youngster and we were writing about biliary injuries, particularly laparoscopic ones, we said there are basically three things that contribute to any laparoscopic bile duct injury. There's dangerous anatomy, dangerous pathology, and dangerous surgeons. I mean, one of those three things is possible in all of them. And I think it's the same thing when you're thinking about bringing up a stoma, as you alluded to. Somebody with a thick, mesentery that's short, that can't be moved, and a thick abdominal wall, it's just not going to reach. You can yank on it all you want. It's probably a bad idea. You do a lot of damage. But, or that there's horrible inflammation around or something. If bringing up a stoma is worse than putting them back together, then put them back together. And in my simplistic view, a foregut surgeon who occasionally does hindgut work, the closer I'm getting to like the pelvic floor, the more likely I am to want to A, do that anastomosis now if I can, and B, if I'm worried about it, do something upstream to protect it that's easier for me to deal with at a later date. But, maybe that's overly simplistic thinking.
No, I don't think so at all. That's exactly how I think of it.
So, but to me, maybe Ozempic will change this. We'll find out in due course. But we got a lot of people with a lot of extra mass, and those people aren't necessarily well suited to getting stomas, or at least they kind of raise your blood pressure while you're trying to create one and realizing it's falling short. But I mean, stoma prolapse, stoma retraction, mucocutaneous separation, peristomal hernias, none of those are good. And so, I'm going to guess that you get a number of people sent to you that somebody else has created a stoma at some point, and now it's not working to people's satisfaction, and you weren't the originator, and or maybe you were. I've had a few that I've had to redo. I mean, we're not immune to it, but so when you're looking at a bad stoma, for lack of a better word, other than, I guess, one guide, if you can get rid of the stoma, get rid of the stoma. But if, so you agree with that part anyway?
Yes, that's the first thing I'm thinking of. What is our strategy to get rid of the stoma if one exists?
Yeah. But but let's say that somebody hasn't had a total proctectomy or they've got functioning sphincter mechanisms. How do you approach the sort of the challenging stoma on a day-to-day basis? I mean, what's your kind of algorithm to look at that problem?
Well, I'm very fortunate in that I've been afforded the opportunity to essentially see my own ostomy clinic where we have time. And so I work hand in hand with an ostomy nurse, and we will see these patients for up to an hour. So my schedule is protected for that time because a lot of it is counseling. Particularly if these things happen in an environment where they didn't have a good stoma nurse to kind of shepherd them through the process. A lot of people simply aren't managing it the way it's supposed to be managed, or don't know what the significance of that effluent, whether it's stool or succus. They don't know the consequence of allowing it to leak out to the edge versus the edge of the appliance versus changing it out immediately. And so a lot of it is just further coaching. Yeah. And most of the quote unquote bad stomas that we get, it's skin complications surrounding it. And most frequently, we can correct that just by resizing the ostomy appliance to get it to the right size, a little bit of coaching on how frequently to change it out, how to change it out. Some people, particularly the patient population you were mentioning with the thicker abdominal walls, frequently those just need a convex appliance. So those small changes, when you sit down and take the time to really talk through it after the dust is settled and they're ready to accept the fact that they've got an ostomy and have to deal with it, that can go a long, long way.
Yeah, and I found, I suspect it's the same, but the community level support, both on stoma nurses and groups and resources and connectivity, seems to have gotten a whole lot better over the last, few decades, for this and getting people, because I agree, probably of all the stoma complications I run across, it's exactly as you say. It's a skin problem 90% of the time. And then the others have their features, particularly the peristomal hernias are probably the next largest group. But there's a lot of resource out there for people. But you're right, and I'm glad you're protected. And when I worked there, I was glad that the Army let us take care of people in what I thought was a very good way. They gave us the time to take care of the patients. Not every practice I've interacted with people in will afford that, and not everybody will demand it. But I think if you're a practicing surgeon, one thing I would suggest to any of them is, if you're a practicing surgeon and you think you need more time to do the right thing for the patient, don't let anybody tell you otherwise. Just stand your ground. Nobody's going to fire you for that and give you a hard time, but you'll get around it. It'll be okay. Good patient care is always the most economical patient care. Moving on to a slightly different topic, but just to wrap it up, and we got a little bit of time here left. There's the last article we're going to discuss is a little tangential, but it's total neoadjuvant therapy for rectal cancer by doctors Affleck and Herzig. And this is, I encourage anybody who's listening to us, go and read this article because it is so dense with all the trials and everything. We cannot in a conversation tell you all the stuff you need to know, but it is in there, But I will say one thing. There's a table in there that talks about the history of this. And it starts in 1985. Now, I started in medicine in 1984, so it's 40 years ago. So the idea that all history before I started didn't exist made me feel incredibly old. I'm like, this is still current events to me. This isn't history, But I mean, if we do look back at the longer historical arc for some of our younger readers, I mean, there was operations only, then kind of operations plus radiation, because chemotherapy in our current form didn't really exist in the early days so much. Then operations plus chemo radiation therapy, and then a series of trials moving forward that they outlined very well in the article from 85 to present. But so just give us your thoughts on the evolution of adjuvant therapy, then neoadjuvant therapy, local control, and overall survival. I'm just going to leave that a very broad question, but if you were trying to explain this to my former residents, your current residents back at Madigan, what would you want them to get out of understanding the general concepts of that?
No, that's great. I think it gets a lot easier to learn this when you do understand the general concepts, because it actually makes a lot of sense. I was fortunate enough to have trained under Dr. Herzig in fellowship, and so he was pretty integral in developing the way I think about this. But the bottom line, and the way that I explain it to the residents and students alike, is that when it comes to rectal cancer, it's a hard area to operate. And so these are tumors in a very challenging location. And that really is the crux of the problem and why we treat it differently than colon cancer. And so we've got two modalities that both are for local control, or getting rid of the tumor itself. And so that is going to be, of course, the surgery and the radiation. Radiation actually existed before surgery for some of these things. That goes way back to the early 1900s, back right when we were first starting to do these operations. And so both of those things essentially do the same thing, though. So in an area that's hard to get to surgically, where maybe in the past we didn't have ideal surgical techniques that came around in like 1990 with Bill Heel talking about total mesorectal excision, that radiation that can help. I guess philosophically, it's wiping out tumor cells just like the surgery. So if there's anything left behind, maybe you get some of those. Similarly, if you give radiation ahead of time, maybe it kills some of those tumor cells that are harder to get to, or makes it smaller and easier to operate. And so it wasn't surprising at all that combining radiation and surgery was going to have better local results than either one of those modalities alone. It's two things that do the same thing combined. We certainly found out that doing it before surgery ended up with better results, meaning doing the radiation before surgery rather than after surgery gave you better patient results. But the real thing that I think brought about this new concept of total neoadjuvant therapy, organ preservation, all these things that the article talks about, stem from the big issue we had even as we got better with local control. So with all our advances in preventing local recurrence in the pelvis, we weren't touching the rate, not significantly touching the rates of metastatic recurrence, because all we were focused on was the pelvic disease, right? And so, we still had 25% 5-year recurrence rates, even when our local recurrence rates were getting down to 2%.
Yeah.
And so how do you address that? And of course, chemotherapy is what's supposed to get rid of those extra circulating tumor cells, even if we don't know about metastatic disease yet. And so we were early on doing it after surgery. But of course, for everybody who's in this game, we know we don't start chemotherapy the day after surgery. There's an inherent delay, usually about a month. And because these are high-risk surgeries in terms of infectious complications, particularly abdominal perineal resections, where you've got lots of wound complications and things like that, well, that backs up the chemotherapy even farther. And what we found, and the article does a nice job outlining this, is that a significant number of patients were not getting their entire planned dose of chemotherapy, and some never even got on to chemotherapy at all. And so it makes intuitive sense to say, well, if we're giving chemo because we suspect they're circulating tumor cells because of node positivity or local advancement or whatever, that why don't we just give it ahead of time? They're more likely to tolerate it before a big surgery, and we can keep an eye on this primary tumor. Chemotherapy does work on the primary tumor as well, but that's a known quantity. We can look at it with imaging. We're already treating with chemotherapy. Why not put the chemotherapy up front and get ahead of the process? And that's kind of how it evolved. And I certainly think that, as this paper points out, the outcomes are very impressive. When you're talking about a 38% all-comers total, not just clinical remission, but pathologic remission rate after giving chemo and radiation up front, really opens the door to not having to do surgery at all.
I mean, I think it's a great point. I think, all the points. The one I would like to underscore is that no patient benefits from therapy that they don't get. If there is a benefit to be had, you have to be treated. And so if you don't make it to getting the chemotherapy portion of it. These diseases are systemic. Cancer is systemic probably just for everybody whenever they get one, whether we know it or not, our immune system deals with it. But the Hallstedian concept of cancer that's a century and a quarter old now didn't survive well the early 70s with the Fisher model. And it's not that they were bad, it's just you got to work with what you got. And now that we're getting more precision medicine and more targeted therapies, we'll probably see that the operative piece is being moved away. I mean, when I was a resident, you had to know all kinds of operative strategies for lymphoma. Not anymore. I mean, nobody's going to ask you too much about doing blind biopsies of the liver for lymphoma anymore. Those went out with a hula hoop. But, that stuff's moving away. But I thought, and there's also things that hang over from our fears. So I'm going to ask you a little bit. So if we look at this, total neoadjuvant therapy, as the article well points out, there's the induction type where you get chemotherapy first and rads latter, and then there's the consolidative type where you get the chemo and the rads up front and then chemo consolidation. The fear of, if I'm so many days, weeks, months away from radiation, I'm not going to be able to do something operative. So, what are your thoughts? So lead us through your thinking on that. I mean, the article has its leadings, but give me your thoughts on that.
Well, I would certainly concur based off my own experience and just, again, being trained by Dr. Herzig. I concur with the article on that. And what they say is that a lot of the fears about pelvic fibrosis that would occur if you push surgery out after radiation, a lot of that was probably unfounded. We have found that the surgery is not particularly more difficult when you wait. And certainly worth it if you can avoid surgery altogether.
I've always said that when we really embrace laparoscopy, the most important thing we learned is that we weren't doing a lot of things right in the open era. That a lot of things that were absolutely you could not violate, turns out it didn't really matter that much. And fear is a powerful, brake to development. I understand that fear and anger and anxiety are all evolutionary protective emotions and so forth, and I get it. But at some point, you got to manage them and work your way through. And I thought that was really well put in the article, is that you can get the big bang for your buck up front and get the chemo up front. And then the natural evolution of that is, do you really need the operative follow-up? So now we get into the watchful waiting part and, the organ preservation. So take us through your thoughts on that.
Well, I think that certainly those studies that have shown complete pathologic response rates that are not significant. In fact, that last one I was talking about with a 38% complete pathologic response rate, again, I think that really opens the door to avoiding surgery. I mean, that is not insignificant at all. And these operations are morbid. Even when they go according to plan, losing a rectum is significantly impactful to patients. And of course, there's a lot of high-value real estate around there too, to include, as you know, those nerves of sexual function and big blood vessels. There's lots of incontinence issues and everything after those surgeries. So avoidance of that is great, as long as you're not sacrificing oncologic outcomes.
The other thing is that, as we've talked about when we work together, operations need to either, for the residents, they need to last until they change service. For the practicing physician, they need to last until you move out of town or until the patient dies or until you retire or something like that. But not every, if you're dealing with somebody who's in their early 90s or something, you don't need a 30-year solution for most of them. If you're dealing with somebody who's in their 40s and 50s, you don't want a 5-year solution. You're looking for something a little more durable, at least in most cases. So I do think you sort of have to look at the risk-benefit equation. And so it all, whenever you get into a watchful waiting scenario of any organ with a neoplastic problem, the question becomes well, if you watch, you must be watching for something. And if you're waiting for that thing to happen, which would be a recurrence. What's your ability to respond to watching and waiting, showing you that it didn't work? So part of it is what do you think is the appropriate evaluation to determine, a complete clinical response. I mean, we know complete pathological response, you got to have the organ out, so we'll discount that for the moment. But a complete clinical response, what do you think is enough workup to call it good for now?
Yeah, that's a great question. So we've actually got some pretty good modalities for looking at the tumor itself and the surrounding lymph nodes. So MRI is really critical to this process because we have found there are features within the lymph nodes themselves that suggest a complete pathologic response. Obviously, we don't have them out. But yeah, to say it's a complete clinical response is based off MRI criteria and physical exam and endoscopic exam as well. So the ones that I've seen, just grossly, it just turns into a flat white scar. So there's really nothing even biopsy. There's no longer a mass. And so when you've got that, it's really hard to argue that a surgery is going to benefit them. And I understand the underlying fear with that, right? And I would say, and I told, especially you alluded to younger patients and, wanting a good durable 30-year solution and all these sorts of things. And as surgeons, we're always thinking surgery gives us that. But the reality is we have local recurrences with surgery. Yeah. We certainly got distant recurrences with surgery. So Sure. It's a little presumptuous to say that the surgery is going to offer a whole lot more when we've had a complete clinical response based off MRI and the eyeball test. Plus, with now pretty good data to suggest that a complete clinical response likely lines up with a complete pathologic response. And when it doesn't, they tend to grow back locally. And if they grow back, from a metastatic standpoint, well, we don't know that the surgery up front was going to prevent them from meting out in the first place. So there's more work to be done, but I feel like we've got enough data now to where we're pretty reassured by this watch and wait concept when we see a complete clinical response.
No, I think you're right. And I think if we look at the data from a lot of other tumors, the idea that we magically catch things before they escape and become metastatic there's a lot of wishful thinking in that. I mean, I guess it's possible, but I think we have to accept that cancer is a systemic disease in almost every situation. That doesn't mean it's lethal or fatal or you can't work around it, but the idea that we're going to get it in the nick of time, I think is a little bit hopeful thinking, but maybe I'm not right on that. One last question on this. So do you see a point, like if you look at this in terms of drugs versus RT or drugs and RT versus drugs and no RT, do you see us coming to a point where drugs alone are going to be the solution? Because for total, in other words, a total neoadjuvant drug-only regimen, or do you see RT as being integral to that no matter what?
Well, so I think that prospect trial they mentioned really shows us that avoidance of radiation therapy can be very effective without compromising your outcomes. The caveat to that is that if you're going to forego radiation based off what we know right now, you're basically taking organ preservation off the table. You are likely not going to get a complete clinical response to the local tumor with chemotherapy alone, even though it's probably treating that tumor. We don't know enough to say we haven't seen a lot where the whole thing goes away after just chemo. And so I can't really speak to chemo versus chemo plus radiation for the complete clinical responder and is watch and wait a viable option. The article states pretty explicitly, and I think the data backs this as well, if you want to forego radiation and just go with chemotherapy because they respond well to chemotherapy and all that kind of stuff, they're still going on to surgery after, regardless.
In the grand scheme, and for the purists out there, they'll tell me I'm wrong about this, you've got the trident of operative management, radiation management, medical management, and that for local regional control, that's what operative management and radiation really allows you. So I guess the bigger question would be is if somebody can come up with a different way of managing the radiation part of it, because there's, I don't want to overly simplify our radiation oncology colleagues' world, but there's a lot of physics and a lot of room to move on how you're going to bombard something with energy beams and damage it. So they may come up with something that's less problematic than standard, single phase or biphase external beam radiation of some sort as well. Any other thoughts on that before we sort of wrap this up? I've kind of kept you a long time. We really appreciate your time and answers.
Oh no, I appreciate you talking to me today. No, I think we're in a kind of an exciting new phase with rectal cancer in particular, and hopefully we'll continue with improvements in chemotherapy, and as you mentioned, maybe even radiation techniques to. I've made it no secret that if I never had to operate on a low rectal cancer ever again because they all went non-operative the way that anal cancer has, I think that's a win-win for everyone. They're challenging operations for sure, and like I said, impactful to patients.
We're really grateful to you and everybody who put this issue together for us. Thank you.
Thank you for joining us for this Surgical Clinics podcast devoted to colorectal surgery. The 4 articles discussed, as well as 14 others, are in the June 2024 issue, Volume 104, Number 3. The series is available for individual print or online subscriptions. Visit www.surgical.theclinics.com to subscribe. The series is also on the Elsevier digital platforms Clinical Key and Science Direct. Be sure to follow us on X/Twitter @Surgical Clinics, and you can find our podcast on most major audio streaming platforms, including Apple and YouTube. Visit theclinics.com for more details. Thanks for listening.